Hi, my name is Maureen Parkinson, and this is part 2 of the presentation on vocational rehabilitation for cancer patients. Now that we have reviewed some of the research and the Canadian Partnership Against Cancer recommendations for work in cancer, I would like to focus more on clinical considerations when working with someone who is coping with cancer and their work. This section will include introducing some conceptual components of a vocational rehabilitation model, which can help guide you when addressing work-related issues for patients, developing an understanding of potential stages of intervention in vocational rehabilitation, briefly discussing a return-to-work hierarchy, which often guides intervention by vocational rehabilitation providers, particularly from the insurance field, reviewing recommendations that patients can follow to facilitate their own return to work, and reviewing recommendations for clinicians to foster vocational rehabilitation. Because research in work in cancer is still very much in its infancy, models of vocational rehabilitation for cancer patients mostly rely on practice related to other illnesses, injury, or disabilities. While borrowing from parts of these vocational rehabilitation models can be helpful, it's important to recognize the uniqueness and the diversity of cancer, its treatments and side effects, and that it is a life-threatening illness. Therefore, further research is needed to incorporate these differences to achieve the best outcomes. To date, there are a few return-to-work models for cancer, which are described in the literature. These include Verbeek and Spelton from Europe, Furstein in the US, and Canada by Dr. Isabella Schultz, the current head of the UBC Vocational Rehabilitation Master's Program. For this presentation, I have expanded the Verbeek and Spelton's pioneering model to include some additional factors that influence work for those who have had cancer. I've replaced the term disease-related, initially described by Verbeek and Spelton, with biopsychological, which takes into account all biological, psychological factors that may pre-exist and continue to be an influence on return to work. System influences were added to reflect the broader influences that exist within a system, such as funding support, infrastructure in certain countries, family and cultural influences, and availability of resources that can facilitate or impede employment. In a nutshell, the biopsych approach includes all psychological and biological factors that precede, emerge, or continue on from the cancer for the patient that influence return to work, including pre-existing conditions such as previous disabilities, for example, mental health conditions, learning disability, or back injury, and its limitations on work choices. Disease specific to the cancer include the unique factors of cancer and its treatment that affect work. The next is the influence of prognosis of the condition, the anticipated recovery, stability, or course of the cancer, other comorbid conditions and side effects of treatment, whether cancer is temporary, chronic, or palliative, and the impact on function or disability on the patient's ability to work, which can include physical, cognitive, or psychological disabilities. Person-related factors or workers' perception of things can influence return to work and job maintenance. For example, how does the patient view the meaning of work? Or how does the patient view the work as part of their life role? What are the patient's expectations around recovery? How recovered do they feel they need to be before returning to work or expanding work hours? What are the cancer patient's attitude about cancer and treatment and its impact on work? Is work reinforcing? Is it a positive distraction from cancer? Is work seen as punishing, such as the belief that stress causes cancer or impedes recovery? Has the diagnosis of cancer changed work priorities? Does a more palliative diagnosis change how one feels about work? System influences on return to work include financial support, wage replacement, how much and how long, which can influence the amount of time off, maintenance of health benefits, or whether someone is self-employed. Economic situation, for example, certain employers may be less likely to accommodate in a negative economic situation. What are the expectations and beliefs of healthcare providers about cancer and return to work? What is the access to medical services to help with recovery and resumption of maintenance of work? What are the legal supports, such as human rights legislation, legislating employers to accommodate those with disabling effects of cancer? What rehabilitation is available through the acute healthcare services, the private sector, and the community to improve or optimize work function? What are the family demands, pressures, beliefs, resources available to support work, and what influences exist in certain cultures that impact work? As we know from the research, worksite factors play a major role for those who have had cancer hoping to remain, retain, or return to work. The number of working hours and times a day can influence whether or when someone can return. Another influence is the job demands. Is the patient physically, cognitively, or psychologically able to do some or all aspects of the job? What parts? Support at the worksite can play an important role. How supportive is the employer to the returning employee? How willing are they to make accommodations? How supportive are the colleagues? What does the employer see as the essential duties of the job? What are the workplace relationships? Is the patient still in contact with the employer, colleagues? Is the relationship with the workplace positive or negative? What is the availability of accommodation? How flexible is the work site, both the employer and the colleagues, to making modifications in hours, duties, what has been in the history of accommodation? Size of the workplace will often influence its capacity to accommodate someone who has had cancer or coping with residual impairment. Typically, smaller companies have less resources available to accommodate disability or illness. Types of work accommodation on the worksite can include transitional work processes, such as graduated return to work, modification of schedules, such as working at different times or starting later, changes to the worksite, including teleconferencing, adapting keyboards, or providing new equipment, modifying the worksite, such as replacing steps with ramps or providing noise proofing to avoid being distracted, job modifications such as changing tasks, or if all else fails, reassignment to available position. The Cancer and Work website has developed job accommodations for common side effects of cancer and its treatment. Of note, these are only suggestions and not mandated by Canadian law, so these are just ideas and employers are not obligated to implement them. Determining changes in function can be an important part of vocational planning. Patient, physician, healthcare team assessments, often from allied healthcare professional, and finally the on-the-job assessment are helpful in determining workability for vocational planning. The first is the patient assessment. As a healthcare professional, we often rely on the patient's self-report of their symptoms to determine their ability to function at work. In most cases, patients have an accurate reflection of their abilities and work expectations, which is very helpful in informing themselves, the workplace, the healthcare professionals about what to expect or anticipate in terms of return to work. There are two parts of the patient assessment: knowledge of their capacity and their ability to do specific work requirements. However, in some cases, due to prolonged absence from the workplace or lack of exposure to job-similar activities, they may have a difficult time accurately assessing their ability to perform the demands of their work. Providing patients with self-monitoring assessments, such as assessments of energizers and drainers and fatigue tracking tools, allows patients to develop a better understanding of their capacity, which can inform vocational planning. To help patients, and for that matter other healthcare providers, determine the expectations of a job, having or completing a job analysis can be helpful in clarifying the job demands. The Cancer and Work website has information on how to determine job demands and how to create a job analysis. In most cases, employers and insurance providers require a physician assessment to describe the limitations of a patient's work capacity and give an idea of return to work date or the need to remain off work. A physician assessment is needed to determine the nature and the degree of impairment, whether the patient has residual illness or injury that affects employability, and whether the patient can return to work and under what conditions. With such an assessment or medical note, the patient may be eligible for accommodations under human rights legislation. For cases where more specific measures of capacity, often an assessment by an allied health professional as it relates to specific workplace requirements can be helpful. For example, physical capacity or functional capacity evaluations by an occupational therapist, physiotherapist, or kinesiologist can often be used in conjunction with a medical evaluation to assess the readiness to safely return to work, whether part-time or full-time, whether someone can do all the physical and in some cases cognitive or psychological demands of the job, or whether someone can do a modified job or graduated return to work, and or recommendations for accommodations. Assessments can involve using specialized weights or machinery or testing someone in a workstation or in some cases on the job. Evaluations can be specific to the job or to assess suitability to other jobs. To assess cognition, neuropsychological evaluations can be very helpful when brain injury may impact cognitive processes. Neuropsychology assessments consist of a series of tests to measure emotional states and cognitive and perceptual abilities. It can pinpoint cognitive challenges and can provide ideas for compensatory strategies and recommend accommodations. Sometimes neuro-specialized occupational therapists can provide cognitive assessments and even worksite evaluations. They can suggest and make recommendations for accommodations that can improve an employee's workability. Of note, the availability of neuropsychology and occupational therapy services varies within region, healthcare system, and within the private sector. A psychological assessment or psychiatric assessment may be called on if it is unclear about the effects of a psychiatric condition, such as anxiety and depression, to determine the eligibility of a claim, or if workability is unclear, or to advise treatment. Vocational rehabilitation assessments are provided to determine what rehabilitation resources need to be put in place to aid in return to work, or to consider alternative work a person could do if they have residual limitations that prevent them from returning to their former job. Lastly, another form of assessment is the on-the-job assessment. The on-the-job assessment can be one component of a functional capacity evaluation where the patient is evaluated at the worksite. Sometimes it's recommended by physicians that patients undergo a graduated return to work trial, which allows the patient to come back to work with reduced hours, then increase the amount of time until full or maximum capacity. The purpose of considering stages of vocational rehabilitation is to help identify opportunities for intervention. Assuming the patient is not working, this is the pre-vocational stage and is everything that precedes return to work to help the patient become more work ready, such as career counseling, rehabilitation, job search instruction, or encouraging attachment to the workplace, etc. For those who are not working at the time of diagnosis, or those who may need to consider other jobs because of job loss or disability, vocational assessment and counseling may be important. Intervention at the worksite involves working with the employee, often at the worksite, negotiating return to work, accommodations and modifications, employer and employee education, on-site assessments such as ergonomic analysis, job analysis, situational assessments, work trials, and job coaching. Job maintenance involves troubleshooting problems while on the job and can include counseling support, continued job coaching, readjusting accommodations, continuing education and communication with the patient, employer, and employees, recognizing that ongoing evaluation and adjustments may be required to address the changing work demands and the ability of the patient. Here is a return to work hierarchy of priority modified from the workers' compensation model, which is often used by insurance providers to guide vocational rehabilitation. It starts with, can a patient return to a job without modification? Can the job be modified? Example, change in hours, duties, tasks, expectations, which is the same job and same employer. Can one transfer the skills to another job at the work site? Same employer. Can one learn new skills at the same workplace? Same employer. Can one transfer skills to another job? Different job, different employer? Can one get another job, different employer? And can one train to do another job, different employer? As you can see, training for a new job is often a last resort. Typically, staying with the same employer has advantages, such as it's a known work environment, maintenance and benefits, and there are human rights to support the worker's return. While the research tells us that many will eventually be able to return to their former job, others may not. As well, for some who return to their former work sites, they may find that preferred tasks have been reassigned to others, or that they may perceive a loss of power or control at the workplace. Counseling can help to manage expectations, accept loss, develop coping skills, and in some cases explore other work options to help them find the best quality life at work. I believe looking at one's avocational activities can be helpful in vocational rehabilitation. Avocational activities typically include non-work activities one does throughout the day, which can include volunteering, caring for others, social and recreational activities, and activities of daily living. If a patient is not able to return to work, avocational activities can provide some intrinsic rewards ordinarily provided through work, and that can be found through volunteering, participating in leisure activities, and increasing social contacts. Trying out avocational activities can be a form of pre-vocational self-assessment to assess capacity, or from a career exploration point of view, to allow one to try other activities to determine if this might lead to a new career direction. Participating in avocational activities can also be helpful to those who are too sick or too disabled to be competitively employable, who are looking for meaning and focus. What if the patient has a more palliative diagnosis? It's important to ask the patient what they want in terms of work. What is motivating them to return to work? What are the rewards that work gives them? Some people, despite a palliative diagnosis, feel strongly about return to work, to maintain a sense of normalcy, to complete work, or to leave a legacy. Part of this discussion is to obtain their understanding and acceptance of their palliative diagnosis. For some, giving up work could mean giving up. Counseling support can play a significant role to help assess capacity to work and to help the person identify what is going on to fulfill their goals or wishes and to support them in that endeavor. Our role as a healthcare provider is to help, if all possible, by providing the medical and psychological information, symptom management, and support for return to work if possible. For those who may be too medically challenged to return to work, it will become apparent soon enough through counseling whether returning to work is realistic. Counseling can help the person access the supports to do what they believe they can and want to do, and if they can't, then to explore how else they might achieve their goals besides work and shift their goals accordingly. Of note, while someone's condition could be considered ultimately palliative, if they are deemed employable by a physician or a healthcare provider, insurers may stop benefits. Part of the intention of creating the Cancer and Work website is to encourage patients to plan their return to work, in most cases early on after treatment ends, so they can feel that they are more in control, anticipate and address the challenges they may face, plan for a job change if needed, and prevent any unexpected negative surprises such as loss of income or job loss. Part of planning to return to work is to encourage the patients to assess their work readiness in a systematic way, such as using an energy log, work simulation, volunteering, etc., to help them have an informed dialogue with healthcare professionals about the challenges, to obtain access to services to improve function, or obtain medical support to stay off work longer for recovery if needed. I often encourage patients to ask themselves what they think is preventing themselves from working now, so they can use this as a starting point to determine what needs to be addressed to help them to get back to work. Part of this is to encourage the patient to ask their doctor about their work readiness and expectation of recovery, which can include questions like what is expected in terms of recovery, how long will this take, will my function become better, will my function level off, will I resume full function, and if so, how long will this take, and when will this happen? While doctors may not know all these answers, this dialogue does encourage planning and manages expectations of the worker and employer. I also recommend that patients maintain or in some cases improve their relationships with employers and colleagues by maintaining ongoing communication to help retain their job and foster goodwill. As we know from the research, the support of the workplace can play an important role in successful return to work. I encourage patients to be more resourceful and consider cancer and non-cancer rehabilitative support, whether in the hospital, health system, insurance providers, within the community, on the web, or self-help education to help them overcome challenges. And finally, I encourage patients to become informed of the options available to them, such as insurance limitations, and attempt to come up with a plan to help them move forward. As a healthcare provider, for those who are expected to return to work, it's important to discuss work concerns early to help with planning and prevent financial hardship. The first step is to start early on by asking the patients about their concerns about return to work. This gives time to find and obtain resources to help address issues. It might be helpful as part of your discussion to know about the job requirements so that you can address any concerns about their ability to do the job early on to help with planning. Part of this is to discuss their work capacity, when they can return, over what period of time, to what extent, and how much they can do. Part of the role of the healthcare provider is to consider how symptom management and treatment planning can be addressed to allow one to remain at or return to work. And if it looks like a patient is not able to return to their former job, discussing the need to return to a modified or alternative job early is important. If it looks like maintaining or returning to work is going to be challenging, I would encourage referrals to vocational rehabilitation support early. Depending on the resource, this could be within the healthcare system, such as the BC Cancer Agency Vocational Rehab Program, through insurance providers, or through community programs, whether cancer specific, such as Wellspring, or provincial vocational rehabilitation programs. If vocational rehabilitation support does not exist, one of the roles of the healthcare provider is to ask third-party insurance or government providers to fund such services. It is also very helpful to explore what return to work support exists at the workplace, in the community, on the web, and in the literature to help patients. It is important to source and direct patients to information on employment rights if they need it. This concludes part 2. I hope this information is helpful to your practice.